Hello, my name is Agte. I'm a PhD in economics at Princeton, and today I would like to talk about my doctoral thesis research, which has been funded by the Center for Health and Wellbeing under the Creative Research Funding Program. So the project is about regulation by competition, the effects of improved public primary healthcare on foreign providers in India. To motivate the project, I would first like to point out that in many developing countries, the informal healthcare sector is often the main source of healthcare for the poor. Whenever I talk about informal providers, I mean here providers shouldn't have a formal medical degree. And I want to understand whether improving the public healthcare sector also in the end can increase the quality among informal providers. To do that, I'm going to examine the reform in India, in which the government is upgrading 150,000 public health posts between 2018 and 2022. And I want to understand whether informal providers react to this increased competition from the public healthcare sector by either lowering the prices or increasing the quality. So overall objective of the study is those to understand the total effects of a public health reform. This means I want to understand how it affects patients, but also how it affects other market providers in the area. And those requested funding for field travel to conduct a pilot study and establish collaboration with the government. For the full project, the plan is to do a randomized controlled trial in which we will randomize the timing of the upgrades for 200 public health outposts. This will ensure comparability between the treatment group and the control group. The plan is to collect information at baseline and endline, so before and after upgrades, through patient surveys and provider surveys. In addition to that, we also want to collect proxies of provider quality, so standardized patients. Here, standardized patients are highly trained surveyors who pretend to be patients and follow a structured protocol and visit the provider to, for example, collect information on the more questions the provider asked and the treatment he prescribes. Talk a bit more about the reform itself. Before the upgrades, health posts mostly focus on maternal and child care. After the upgrades, they also provide basic outpatient care and also manage non-communicable diseases. This means that before the upgrades, if you're, for example, an adult in a village in India and you have fever, you usually have the option to travel for half an hour to the nearest town, to go to the public health clinic, or to seek healthcare at the informal provider in your village. After the upgrades, you will also have the option to directly go to the health outpost in the village to receive basic care. And the two components of the upgrades are, first of all, that these health outposts receive an additional mid-level provider, and that they also receive an expanded set of medicine diagnostic tools. What I did now was to go in last fall to India to assess the role of the reform. We did a pilot study in 15 villages. We were supposed to have an upgraded sub-center. And reassuring what I found that 14 of the 15 health outposts were upgraded according to plan and met official guidelines. This means that the new additional mid-level provider was present, and also that the expanded set of medicine was in stock. Even more so, I found that the monthly patient load increased drastically after the upgrades, from around 100 patients per month to 370 patients per month after the upgrades. This shows that patients really valued the reform. And I also found that in 7 of these villages, at least one foreign provider was present. Quality of interviews with providers suggests that these providers lost patients due to the reform, and they also reacted by lowering the prices. So given this evidence, it seems to be that there is support for the research hypothesis. And I went again to India last spring to, in the end, secure approval from the government to randomize the rollout. And the current plan is now to target the March 2021 rollout for the immunization. However, due to the COVID pandemic, also with government changes, there might be a delay in the rollout. Overall, the initial results suggest that it's important to incorporate, take into account the individual responses of other healthcare providers when evaluating public health reforms. But there's still open questions of whether, so we also see changes in health quality among providers, whether patients actually know about the quality of providers, and also what are the remaining barriers to healthcare access. Overall, the results suggest that the project seems feasible and also helping to secure larger grants and also helping to file into secure government approval. So in the end, I would like to thank the Center for Health and Wellbeing for funding this research. I would like to thank my advisors, Professor General Curry and Thomas Fujiwara, for the continued support, and finally, Professor Asia for helping me with you. Thank you very much.